Hey everyone, and welcome to this high-yield explainer of the 2018 RCOG Green-top Guideline on Vasa Praevia. We designed this specifically for MRCOG candidates and clinicians who are looking for absolute mastery over what is, honestly, one of the most high-stakes obstetric emergencies we ever face. Today, we're going to cut right to the chase and distill the essential diagnostic criteria and management protocols straight from the source. Here is our clinical pathway for today. We'll be moving systematically through 5 sections: defining Vasa Praevia, diagnosis and screening, undiagnosed delivery emergencies, antenatal management protocols, and finally, the timing of elective delivery. Let's jump in.
But real quick, before we really get into the weeds, you've got to lock in this RCOG grading system. Throughout this explainer, we're going to anchor every single crucial management step to its specific evidence grade or good practice point. Because, for your MRCOG exams and your daily practice, simply knowing what to do is only half the battle. Knowing the strength of the evidence behind your decision, well, that's what actually makes you a safe, definitive clinician.
All right, Section 1. Let's establish the core pathophysiology of this condition.
So, the fundamental issue here is the anatomy. Vasa Praevia happens when fetal vessels run directly through the free placental membranes. And what makes this so uniquely dangerous? Well, think of it this way. These vessels are completely stripped of their protective armor. They have zero placental tissue and absolutely no Wharton's jelly to cushion them against compression or tearing. Whether it's a type 1 scenario connecting to a Velamentous cord or a type 2 bridging a Succenturiate lobe, these totally naked, vulnerable vessels basically become a ticking time bomb when they're sitting right over the cervix, especially once active labor starts or during an amniotomy.
And this comparison brilliantly illustrates the ultimate stakes of our discussion today. When we manage to secure a prenatal diagnosis, the fetal survival rate is an incredible 97%. But, and this is a massive but, if this condition goes completely unnoticed and is only discovered intrapartum, that survival rate violently plummets to just 44%. More than half of those babies are lost. So the really obvious question becomes, how do we ensure we're always landing in that 97% cohort? That is exactly why truly understanding the rest of this guideline is absolutely critical.
Moving right along to Section 2, let's examine how we actually secure that life-saving prenatal diagnosis. You absolutely must remember that the highest diagnostic accuracy isn't achieved with just a single view. No, it requires a combination of both transabdominal and transvaginal color Doppler imaging. The guideline gives this a grade D recommendation. So why do we need both? Well, the transabdominal sweep gives you that crucial spatial overview, while the transvaginal approach completely overcomes any acoustic shadowing from fetal parts. It drastically improves your grayscale accuracy by letting you directly visualize the flow and capture those fetal vascular waveforms on pulse Doppler right straight through those aberrant vessels.
Now, this brings up a classic exam pitfall. You might be wondering, if prenatal diagnosis saves so many lives, shouldn't we just screen every single pregnant patient for Vasa Praevia during their routine anomaly scan? It makes sense, right?
Actually, no. The guideline explicitly states there is insufficient evidence to support universal screening in the general population. It's a grade D recommendation. While it might seem completely counterintuitive when we just talked about how early diagnosis saves lives, attempting to screen every low-risk pregnancy would yield a massively high false positive rate, and that would just trigger a cascade of unnecessary maternal anxiety, totally avoidable hospital admissions, and a really dangerous spike in iatrogenic premature deliveries. So instead, the RCOG mandates a highly targeted approach.
Because up to 83% of Vasa Praevia cases present with one or more identifiable risk factors, you have got to commit this high-yield list to memory for targeted mid-pregnancy screening. I like to think of them in categories. First, you've got placenta location issues, like a current low-lying placenta or placenta previa. Second, anatomical anomalies, things like bilobed or succenturiate lobes and Velamentous cord insertions. And finally, patient history, specifically pregnancies that are the results of IVF. If any of these are present on the anomaly scan, your clinical index of suspicion for Vasa Praevia must go up immediately.
Okay, Section 3, undiagnosed delivery emergencies. Let's see how all of this builds into the rapid-fire actions you have to take during an emergency on the labor ward.
You need to recognize this classic clinical presentation instantly. It's Ben-Kazur's hemorrhage, which is painless vaginal bleeding that occurs right after spontaneous or artificial membrane rupture. And here is the terrifying physiological reality behind this. The total fetal blood volume at term is only about 80 to 100 milliliters per kilogram. To put that into perspective, a term fetus only has roughly a teacup's worth of blood in its entire body. So even a seemingly trivial amount of vaginal bleeding represents a massive, catastrophic hemorrhage for the baby. It leads to profound and acute fetal compromise in a matter of minutes.
If this happens, you do not delay delivery to hunt around for a diagnosis if fetal well-being is already crashing. You must fire off a rapid sequence of interventions. Immediate emergency caesarean delivery and simultaneous neonatal resuscitation, including an urgent blood transfusion if they need it, is a grade B recommendation. Then, following delivery, the guideline outlines a really critical good practice point. You absolutely must send the placenta for comprehensive pathological examination. That confirms the retrospective diagnosis of Vasa Praevia, it provides vital answers for the parents, and it is totally essential for medical legal clarity if there's acute compromise or stillbirth.
All right, so we've covered the worst-case emergency scenario. Section 4. Let's look at the ideal situation, how we manage a stable patient when we actually have that confirmed prenatal diagnosis. Here's a massive point for your clinical management. A good practice point dictates that it is absolutely essential to confirm the persistence of Vasa Praevia by ultrasound in the third trimester, usually around 30 to 32 weeks. Why? Well, as the lower uterine segment forms and expands, the placenta undergoes trophotropism, which basically means it migrates upwards. Because of this natural shift, roughly 20% of cases diagnosed in the second trimester actually resolve completely naturally before delivery. So confirming persistence is a must to prevent totally unnecessary anxiety and to block harmful iatrogenic prematurity. The 2018 update actually brought a major paradigm shift to modern practice here. It introduces a good practice point to move entirely away from blanket routine hospitalizations from 30 to 32 weeks. We just don't automatically admit everyone anymore. Instead, the decision for prophylactic hospitalization has to be highly individualized. You're evaluating the patient for compounding risk factors. Are they carrying twins or triplets? Have they had any sentinel antenatal bleeding? Are there any signs of threatened premature labor? If the answer is yes, then you admit.
So, for candidates wondering exactly who gets to safely stay home, these 4 strict criteria outline the safest profile for outpatient management. Your ideal candidate is entirely asymptomatic, they maintain a stable and long cervical length on transvaginal ultrasound, they have zero history of antenatal bleeding, and they show absolutely no signs of premature uterine activity. If they fit this exact profile, and crucially, if they live within a very rapid distance to the hospital and are counseled to come in immediately at the very first sign of bleeding or contractions, then outpatient management is incredibly safe and associated with really excellent outcomes.
And finally, Section 5. Timing of elective delivery. This is highly testable and incredibly critical for your clinical practice.
You will definitely want to lock this exact golden timeline into your brain for your exams. Between 30 and 32 weeks, your job is to confirm persistence via ultrasound and individualize that hospitalization decision. Moving to 32 weeks, because of the inherent unpredictable risk of preterm delivery with this condition, you must recommend corticosteroids for fetal lung maturity. That is a heavily tested good practice point. And finally, for stable asymptomatic women, the planned elective caesarean delivery should be scheduled squarely between 34 and 36 weeks of gestation. That's backed by a grade D recommendation.
Basically, this clinical timeline perfectly distills the delicate balancing act at the very heart of this entire RCOG guideline. Delivering between 34 and 36 weeks is the ultimate sweet spot. The goal is to safely deliver the fetus via elective section before an unpredictable and catastrophic rupture of membranes occurs late in the pregnancy, while simultaneously pushing the gestation far enough along to actively minimize the severe respiratory risks, the neurologic risks, and those lengthy NICU stays that are associated with iatrogenic prematurity.
So as we wrap up this explainer, I want to leave you with a final challenge. We saw the data earlier, right? The survival rate leaps from a devastating 44% to a phenomenal 97% when we spot this in advance. With targeted screening based on specific anatomical markers, the power to catch this early is quite literally sitting right there in your ultrasound probe. So, how will you elevate your everyday clinical vigilance to ensure no Succenturiate lobe or Velamentous cord slips by you unnoticed? Master these evidence grades, trust your targeted screening, and use this structured approach to ace your exams and, most importantly, protect your patients.